Great, good afternoon, everyone. Welcome and thank you for joining us today. Before we get started, we just have a couple of quick announcements. This seminar is being recorded and the recording will be posted on our website and available by email after the event. All participant microphones are muted, so if you have any questions or comments during the seminar, please enter them into the Q&A box in your WebEx panel, as there will be time for questions and discussion towards the end of the presentation. Now I'll hand it over to Dr. Belinda Reininger to kick things off. Thank you.
Thank you, Ricky. Good afternoon, everyone. My name is Belinda Reininger, and I'm a professor and regional dean at the UT School of Public Health in Brownsville. And I'm the co-director of the community engagement component of the Center for Clinical and Translational Sciences. It is my pleasure to welcome you today. The Center for Clinical and Translational Sciences is proud to co-sponsor this event. This center is an NIH-funded center that involves multiple universities, including UT Health Houston, MD Anderson, Rice University, UT Health East Texas, and UT Rio Grande Valley. This center creates partnerships across institutions and researchers from multiple disciplines and with communities to increase the translation of research findings into population impact. It is my pleasure to have the opportunity to introduce our speakers today, both of whom are experts in their field and whom I know you're going to enjoy listening to. The first speaker is Dr. Bijal Balasubramanian, and she is an associate professor of epidemiology and the regional dean of the UT School of Public Health in Dallas. She is a primary care physician and an epidemiologist. She's a leader in the field of primary care practice change research, where she applies implementation science methods to enhance adoption and implementation of evidence-based practices and guidelines. Thank you, Bijal, for speaking with us today. Our other speaker is Dr. Maria Fernandez, and she is the Lorne Bain Distinguished Professor in Public Health and Medicine, Professor of Health Promotion and Behavioral Sciences, and the Director of the Center for Health Promotion and Prevention Research at the University of Texas School of Public Health in Houston. She's an expert in implementation science, particularly in the areas of adaptation of evidence-based interventions, implementation of multi-level cancer control and chronic disease interventions, systematic planning of implementation strategies, and implementation research to advance health equity. She leads the dissemination and implementation efforts in our TIIS, our Clinical and Translational Science Center. I'm going to now turn it over to Dr. Maria Fernandez, and thank you both for your work.
Thank you very much, Belinda. I'd like to welcome you all to the Texas Institute for Implementation Science inaugural webinar and workshop series. Just to remind everyone, the webinars are open to everyone. And then the workshops were designed to build capacity in implementation science in Texas. And the applications for that workshop are closed now. But as I said, this is an inaugural seminar and workshop. And so we hope to do this yearly. The goal of the Texas Institute for Implementation Science is to foster and support implementation science in Texas and beyond, to improve population health and health equity. And we're really excited to be kicking off the series with this introduction to implementation science today that Bijal and I will be talking about. In our upcoming webinars, though, we have 3 world-renowned experts sharing their expertise in cutting-edge work. Dr. Wandersman will present on the concept of readiness for change in implementation. Dr. Curran will describe the ins and the outs of implementation research study design, particularly hybrid designs, which I know you all are very interested in. And Dr. J.D. Smith will give us an overview of cutting-edge methods in implementation science. So without further ado, I'm going to go ahead and turn it over to Bijal. Bijal, if you're talking, you're on mute.
Yes, I was. Thank you. So thanks, Maria, and thanks, Belinda, for the introduction and the overview of this inaugural implementation science conference and workshop. And I'm really excited to kick it off with this talk with you, Maria. And as part of this talk, I will give a primer and introduction to implementation science and really highlight the importance of the discipline. Maria is going to delve a little deeper into strategies and theories and conceptual frameworks. So I like this quote because I think it really exemplifies why implementation science as a discipline is important. So a little knowledge that acts is worth infinitely more than knowledge that is idle. As we all know, there are a lot of really great and efficacious solutions that often fail when implemented again or when implemented in the real world. And we are also aware of examples and knowledge that is idle. And I think implementation science provides us with methods and tools to not only better translate knowledge and known efficacious solutions to practice, but also then design interventions with an eye to successful implementation and dissemination further. Next slide, Maria. Thank you. So many of you may have heard about the research practice gap. This is the research practice gap is the time it takes for new discovery or effective interventions to be implemented as usual care or standard practice in the real world. And we know that we have a lot of challenges translating research into practice. And this figure is from a study by Balasubramanian in 2000 that exemplifies what these challenges are and the time it takes. So it shows that moving from original research to population health impact and widespread implementation takes a lot of time. From conceptualizing original research, going through the scientific publication process, getting that research into bibliographic databases, and then finally into reviews, guidelines, and textbooks such as clinical practice guidelines that then can be implemented in clinical and community organization takes, next slide, takes up to 17 years. So you might have heard about this quote a lot because it's out there. It takes 17 years to turn 14% of original research to the benefit of patient care. Next slide. So this cartoon depicts that we need new research to effectively close this gap between research discovery and successful delivery of effective programs at scale. And the field of implementation science for over the last 15 years or so has been working towards coalescing these methods from a lot of other related disciplines, developing new methods, and identifying areas where principles of implementation science can help close this research to practice gap. And Dr. Fernandez is actually going to highlight some of these new and emerging areas a little bit later in the presentation. Next slide. So to start with the basics, of course, it's important to start with clear definitions for this somewhat newer area of research. So the National Institute of Health has a program announcement on dissemination and implementation research in health that defines implementation research as the scientific study of the use of strategies to adopt and integrate evidence-based health interventions into clinical and community settings in order to improve population health outcomes. So implementation research seeks often to understand the behavior of practitioners and support staff and organizations in and contextualized within the context as key influences on adoption, implementation, and sustainability of evidence-based interventions and guidelines. So it goes back to the concept that we have good evidence, but a lot of good evidence is not being translated into real-world practice. And what are the methods and what is the research that we need to get that evidence into practice? And that's what implementation research is focused on. Another concept is dissemination research, which the program announcement defines as the scientific study of targeted distribution of evidence, which is knowledge or interventions, practices, or policies to a specific public health or clinical practice audience. And the intent here is to understand how best to spread and sustain these evidence-based interventions. So what we are currently missing is critical information about how, when, by whom, and under what circumstances such evidence spreads throughout communities and clinics and organizations. And dissemination research helps to generate this critical information. Next slide. So right off the bat, I wanted to acknowledge that it's really important to understand and acknowledge that implementation science is inherently multidisciplinary because of the overlap of many different fields of research that make implementation science what it is. And this includes areas or disciplines, fields of research such as health services research, health communication research, equality improvement science, dissemination and implementation research that together help in quality improvement and in spread of the evidence that's developed, as well as to implement it in context. And I wanted to acknowledge this because a lot of you may already be working in some of these areas of research, and that they feed into each other. And you know, this is sort of we struggle with the fact that this is a Venn diagram of circles within circles. Yet it exemplifies the multi-level influences and the multidisciplinary nature of implementation science. Next slide. So I wanted to take a few minutes on this slide to show this model that helps us understand how the traditional translational pipeline then feeds into what I think of as the implementation pipeline, or the dissemination and implementation research pipeline. So many of you be familiar with the idea of studies where where there is an intervention that goes through some feasibility, acceptability kind of pre-intervention work, development work. And then we have efficacy and effectiveness studies to determine if that intervention is in fact efficacious and effective in improving the outcomes that you state, and I'll say about that in a couple of minutes about what the differences are in outcomes. But typically, these outcomes are clinical outcomes or public health, health behavior improvement outcomes. And often the translational pipeline ends at an effectiveness study with very little attention to the translation of that evidence-based information into implementation. And that's what this yellow box is about, where you then take that and try to understand not just does the intervention work, but how the intervention works. So what do we need to know to make that program work, as this other sort of parallel pipeline is showing. And part of that includes exploration, adoption of the intervention, studying the implementation of the intervention, and eventually the sustainability of the intervention in real world practice. So the focus of that yellow box then is more how a program of intervention works, what are the strategies that are needed to make the program work. And as you go from exploration to sustainability, the focus then changes from generating local knowledge, for example, on how an intervention may be adapted and implemented for a particular setting, to generating generalizable knowledge about what works in different settings and across different health conditions. You also note the axis here of real-world relevance, which as you go from pre-intervention and efficacy study towards implementation, the real-world relevance of the work increases. Next slide, please. So the ultimate goal of a program of intervention, therefore, if we think about it, is to have long-standing impact on public health. And this requires a program to not only be effective, of course, but also to have widespread reach. And so I wanted to give you an example of such a program. So CATCH, which is Coordinated Approach to Child Health, is an example of this long-standing impact of a proven intervention when that translational pipeline incorporates implementation research study. So what CATCH did is it unites multiple players in a child's life to create a community of health. And CATCH through its early efficacy and effectiveness study, is proven to prevent childhood obesity, and then supported by over 25 years of further effectiveness and implementation studies, has proven to decrease overweight and obesity rates. CATCH was first developed in the late 1980s, funded by NHLBI, and it was a collaborative effort of many universities, including ours here at the School of Public Health. And it was the largest school-based health promotion study ever to be conducted in the United States. And so after establishing the effectiveness of this program in its efficacy studies, but also in several different settings, there were numerous implementation studies that focused on how to increase adoption and reach of the intervention, and then scale up and scale out more broadly. And this sustained effort to study implementation has helped get this program out nationally. Next slide, please. So having given a little bit of a broader overview, I wanted to get into just a bit more detail about what is the difference between a clinical or a public health research study and an implementation research study. So what you see in this table is that the aim of a public health or a clinical research study is often to evaluate a clinical intervention or a health promotion or policy intervention. And typically the intervention is a drug, a procedure, a prevention program, and often the outcomes of interests are improving symptoms or health outcomes or patient behavior. And the unit of analysis or randomization is also often an individual patient or a community member. The implementation research study, on the other hand, aims to evaluate an implementation strategy. And so typically the intervention is, for example, practice change, training, audit and feedback, and the outcomes of interests are not health outcomes, but rather outcomes related to how well the intervention was adopted, how well the intervention adhered to the principles, was it done with fidelity, what was the success in implementing it. And the unit of analysis of randomization is often a clinic, a team, a facility, a school, in essence, an organization. Next slide. So here's an example of one of my recent studies that I think depicts this difference between clinical research and implementation research quite well. So in 2017, there were new clinical guidelines that came out recommending the use of statins for those at increased risk for atherosclerotic cardiovascular disease. And these guidelines came about from clinical research studies, clinical interventions, evaluating the efficacy of the use of statins, prescribing statins to patients at increased risk of ASCVD. And the typical outcome of those studies would be prevention of CVD events such as heart attack and stroke. And of course, these studies are done at a patient level. We're trying to understand if statins help patients help reduce the occurrence of CVD events. On the other hand, for implementation research, the Agency for Healthcare Research and Quality funded the Evidence Now initiative that I'm involved in, where the focus was on testing interventions to evaluate strategies such as facilitation, coaching, clinician and staff use of an ASCVD calculator, and prescribing new workflows to then see if the prescribing of statin could be adopted, adhered, and implemented within primary care clinics. And so I hope you can see that clinical research and implementation research difference here. Next slide, please. So this is a model from a seminal paper by Proctor et al. In 2009. It's old, but it's still very, very useful in thinking about how to study implementation. So our usual way of clinical research is that evidence-based interventions or interventions, when implemented, affect some health outcomes, which may be health status, symptoms, quality of life, so on and so forth. Implementation research, on the other hand, focuses on a different set of interventions that are called implementation strategies. And Dr. Fernandez will go into that in a little more detail. And a different set of outcomes that then help us understand whether implementation was successful, and the outcomes are focused on whether the intervention was feasible, acceptable, and just to remind you, in this case, the intervention is the implementation strategy. And whether the strategies penetrated through the organization, were they sustained, whether there was an uptake, and what it cost to do that. And together, from going from evidence-based intervention to the strategies, to the implementation outcomes and the larger health outcomes, we found this larger implementation pathway. I like this model a lot because it really, again, helps us conceptually connect the dots between original research all the way to translating it to practice. Next slide. I wanted to then also highlight a few challenges that are inherent in implementation and dissemination research studies. Perhaps I'll go a little bit out of order here because I want to highlight the last one first, which is researcher-focused studies. So we're all familiar with it because there's so much attention to designing very internally valid, strong studies, but with very little attention to external validity. And that's where it's extremely challenging to close that research to practice gap. And we need to pay more attention to external validity while also designing rigorous internally valid studies if the translational pipeline must be cut down in terms of time. Implementation and dissemination research studies also have other challenges that are related to limited involvement of stakeholders and policymakers. And this one's also really important because the two sides of the coin, although I think it's getting better, often don't agree because researchers may complain that practitioners pay little heed to research findings, and practitioners may counter that research isn't always relevant to real world practice. And what this tells me is that we really need to design interventions that have stakeholder input. And I'm sure a lot of you are starting to hear that in also coming from funding agencies such as PCORI, where we have to demonstrate significant stakeholder engagement. And I think that that's the right thing to do. And these are all critical challenges that we need to acknowledge and address as we implement our research programs. Next slide. I wanted to just share a few developments in the field and resources that are available. So the two things on the top show Implementation Science and Implementation Research and Practice as two journals now specifically catering to and publishing research from D&I. 3 textbooks that really lay the foundation of the methods. And at least 2 conferences that I'm listed here, which is Society for Implementation Research Collaboration and the Dissemination and D&I meeting, we call it the D&I meeting, that is now, I've been going to these for 2 or 3 years. I know Maria has been going to it for over a decade. And it's really a great place to feature your work and publish your work and get to learn from other colleagues. Next slide, please. So to round just my high-level overview, the focus of implementation science, as I've been saying, really is to produce generalizable knowledge regarding these implementation strategies by understanding the different processes, barriers, and facilitators that can influence success or failure in implementation. Secondarily, it aids in the development of testing, refining of theories and conceptual frameworks, as well as measures to advance implementation science. And finally, helps to develop effective strategies for implementing a lot of this really good evidence-based practices and programs to improve health-related process and outcomes. With this, I'll hand it over to Dr. Fernandez to talk more, and I think she's going to jump in right with implementation strategies.
Sorry, apparently I couldn't unmute myself while I was in slide mode. Can everybody hear me?
Yes.
Great, thank you. Thank you very much, Bijal. So I'm going to talk about implementation strategies briefly, and then I'm going to talk about theories and models and implementation science. And then I'm going to end with talking a little bit about planning implementation strategies and some new areas of research, emerging areas of research in implementation science. So the topic of implementation strategies, as Bijal mentioned, is a central one in implementation science, because we can understand what factors might influence implementation and develop measures and develop lots of really interesting and innovative theories and models to better characterize what happens during implementation. But ultimately, what we want to do is we want to improve it. And so that's what implementation strategies are. They're defined as methods or techniques that are going to enhance the actual use of clinical programs or public health programs and practices. And there's a number of different definitions. Some people call them implementation interventions, knowledge translation interventions. But there's really a consensus in the field now that implementation strategy is really the term that we should use. And part of that is so that we don't get it mixed up with what we're trying to implement in the first place. And I'll leave more of a discussion about how you distinguish between what you're implementing and how to implement it to Jeff Curran, who does a great job in doing that, and he's one of our speakers. So types of implementation strategies have been defined as discrete, which are single action or processes, multifaceted, which I would say are the most common, which include a combination of multiple discrete strategies, and then blended. And these are multifaceted strategies that are sort of packaged or protocolized in some way, and often they're branded. So there's a number of taxonomies of implementation strategies that have been developed, and perhaps the most widely used are the ERIC strategies. And these originated from a team led by Byron Powell that first presented this consolidated compilation of discrete implementation strategies based on a review of over 200 sources published between 1995 and 2011. And they came up with 68 implementation strategies and definitions. And then the compilation was refined through this expert recommendations for implementing change. And that's where the term ERIC comes from, which engaged 71 experts in implementation and clinical practice in a modified Delphi process. And then another study, the one that's shown here, provided initial validation of the implementation strategies within the ERIC compilation as being conceptually distinct and provided ratings of importance and feasibility. So this is a compilation that many people refer to and rely on when thinking about what should we do? What should we do to enhance implementation in various settings? These are just the various categories. I like to think of them as buckets of those 71 implementation strategies. And they're, as I mentioned, they are often very useful for folks who are trying to think about what's the type of implementation strategy that we need to use for a particular implementation problem. And then within that type, what are some specific experiences that others have had in trying to implement these different strategies? Now, I want to point out, however, that especially for those of you who are thinking, oh, great, there's a list and we can just pick from this list, that there are challenges in selecting implementation strategies. And some of them include that these compilations that have been developed may be less relevant for certain settings. The ERIC strategies were developed looking at literature from essentially healthcare and also mental health in particular. And they may be less relevant for other settings such as public health or community settings, although they are now being used much more in those settings, and many of them are being found to be really helpful. The strategies included in the compilations are kind of broad and may represent qualitatively different things. So if you look at the list of strategies, some of them are delivery channels, others are assessments, others are processes. And there's also just limitations in the empirical literature in describing the usefulness of these strategies and limited evidence about the effectiveness of some of these strategies. So if you think about them as a list that can help guide you, then I think they can be really useful. And as we build the knowledge base and understand what strategies work for what, then I think that we're going to go a long way and actually having a list that we'll be able to choose from more effectively. The other issues related to, and challenges related to the selection of implementation strategies also includes the underutilization of conceptual models and theories that can help guide you about what types of implementation strategies may be more useful, and also variations related to evidence-based programs and the differences between different programs, and then the context in which they're implemented. So because of this, as I mentioned, we have a lot of work to do in the area of implementation strategies. And this was an article that was published last year that Byron led and I participated in, where we set a research agenda for implementation strategies. And basically, there's 4 main areas that we think that are very important, among others. But these include the specifying and testing of mechanisms. So what we don't really know is why a particular strategy may work in one setting and not in another. What are the mechanisms of change? What are the methods? So there's a lot of terms that have been used. There's also been distinctions. Brian Mittman talks a lot about form versus function. And so there's a lot of work in this area that needs to be done. Also improving the description, tracking, and reporting. Poor description and tracking limits the replication in both science and practice around implementation strategies. And it also precludes answers to how and why strategies work. Increased economic evaluation is another really important area. And then enhanced methods for developing, selecting, and tailoring strategies. And I'm going to talk to you a little bit more about that last one in a minute. But first, let me just give you a quick tour of theories, frameworks, and models in implementation science. And it's not really going to be a tour. I'm just going to give you some concepts around these and how you might want to think about them, and also give you an example of some of the most commonly used ones. So first, these terms, theories, framework, models, they're used interchangeably, and they've been defined in different ways. But the way that I like to think about it, and the way that they've been defined before, is that theories present a systematic way of understanding events or behaviors or reality by providing interrelated concepts, definitions, and propositions that explain and how these various constructs within these theories predict events or help you understand events, and they specify relationships among the variables. By definition, they're abstract and they're broadly applicable, so they're not content specific or topic specific, which is great because that means they can be applied across a number of different settings and topics. Frameworks are similar in some ways. They're strategic or action planning models that provide sort of a scaffolding, a systematic way to think about things that can help you develop, manage, evaluate interventions. But one of the things that's different about frameworks is that they don't typically have as much evidence in how various constructs within those frameworks actually predict outcomes. And they rarely have research that has established the relationships within the constructs in that framework. Now, the goal, of course, in implementation science, which has many frameworks, would be moving from frameworks to theories, so that as we build the knowledge base, we start to understand the relationships among these constructs within frameworks, so that we can more accurately in the future predict implementation outcomes. I use the term models as a more generic term that describes theories and frameworks collectively. So what can the use of theories and frameworks and models do? They can provide a systematic structure for the development, management, and evaluation of your interventions. They can help inform the selection or development of strategies. They can help you interpret your study findings and why something did or didn't work, and provide guidance about what to measure. And also, ultimately, as I was just saying, that as we develop these theories, we're going to get a much better understanding about implementation in general. Now, there's no comprehensive model that seems to be appropriate for use in any study or focus and helping you focus the implementation of a particular program. And although there are a lot of models, not all of them are well operationalized, right? So it's important to be aware of what's out there. There's some really excellent resources. We list some of them later on in the presentation, and Bijal already listed some of those resources that describe these frameworks. It's also important to consider that these models are not static, but they may change over time. And a goal in this field is to make refinements and advancements to these models. One study that I think really helps in trying to understand all of these different models and frameworks that are out there is a study conducted by Fernandez, who did a scoping review of all of these frameworks and kind of categorized them, right, and described them as process models that are essentially guiding the process of translating research to practice, frameworks or models that help understand the influences of implementation, and then evaluation frameworks. And then that second category can be further broken down into determinants frameworks, classic theories, and implementation theories based on descriptions of their origins, how they were developed, what knowledge sources they drew on, and then stated aims about their application and implementation science. So these I find really helpful because sometimes you need different frameworks for different pieces of your study. So just quickly, let me check on the time here. We want to leave time for questions. So I'm going to go really quick through some of these, and but happy to entertain some more questions if people are interested. So REAIM, the consolidated framework for implementation research, and the interactive systems framework is just a sampling of frameworks that are often used. The REAIM framework is intended to facilitate translation of research to practice. It places equal emphasis on internal and external validity issues and emphasizes representativeness and helps in understanding ways of measuring key factors involved in evaluating the potential for public health impact, right, and widespread application. So because of that, it has these, it's an acronym, right, that consists of reach, efficacy, adoption, implementation, and maintenance. And so as you can see that in this framework, we're not just worried about or concerned with whether or not an intervention works, but also its ability to reach the population. And that combination of reach and efficacy, as Bijal mentioned before, is what ultimately leads to impact. But that only happens if these interventions are adopted, if they're implemented, and if they're maintained. I use the REAIM framework a lot, particularly in framing the evaluation of the work that I do. Another framework is the Consolidated Framework for Implementation Research, developed by my good friend Laura Damschroeder and her colleagues. This is, I find, one of the most useful determinants frameworks that's out there. And part of the reason I think that it's very useful is that it's an overarching typology that builds on Trish Greenhalgh's work, where she synthesized over 500 sources, plus new other sources that Laura and her colleagues looked at. And so it becomes a meta-theoretical sort of synthesis of existing theories. However, there's no depiction of interrelationships between the constructs within this. And just to quickly explain, so there's a number of different, I'll go to the next slide. So there are these 5 major domains: intervention characteristics, which those of you who are familiar with diffusion of innovation theory, there's a lot of similarities there. What's happening in the inner setting, what's going on in the outer setting, the characteristics of the individuals involved, and then the process for implementation, right? And so it's depicted in this figure. And over here, this represents the intervention, and you can imagine it sort of moving through this setting. Let's say it's a primary care setting, and it comes out the other end in an adapted way, right? So it's rarely looks exactly like it did here at the beginning, and its influence and the extent to which it is effectively implemented is influenced by all of these factors. And then within those domains, there's a number of different factors. The last one that I'm going to mention is the interactive systems framework. And this framework has become more and more popular. It's saying that there are different actors and different systems that need to be involved if we're going to have successful implementation. There's 3 different systems. And if you look at it from the bottom up, the synthesis and translation system is responsible for making sure that the evidence will actually inform implementation, packaging it in a way that is usable. The support system helps to make sure that the capacities and motivation is in place to support what needs to happen in the implementation effort. And then the delivery system is actually includes those individuals that are involved in delivering the intervention or the innovation. And you'll see, and I'll mention a little bit more about this in the next slide, that these contain elements of general capacity, innovation, specific capacity, and motivation. And these particular constructs have led to the development of the R equals MC square heuristic, or readiness heuristic, that Abe Wandersman and his colleagues have developed, and he'll be talking about readiness, so I'm not going to go too much into it in the next webinar of our series. But essentially, readiness is a combination of motivation, innovation, specific capacity. Do you have the capacity to do this particular thing? And then general capacity, which is the aspects of organizational functioning like culture, climate, staff capacity, leadership. And the idea of this stool is that really to be stable, in order to be ready for implementation, these things have to be in place. So what are some of the things that you should ask yourself when selecting a model or framework? You have to know, what are the research questions you're seeking to answer? What is the level of change that you're seeking to explain? What characteristics of context are relevant? So these are just various things that you want to think about when you're choosing a framework. And one key thing is that you might want to ask yourself, are there specific theories or frameworks or models that relate to different aspects of the proposed research? So there may be a framework, for example, CFER, that helps you understand the determinants. But then there's another that helps you adapt a particular existing program for a new setting, and another that helps you define outcomes. Now, you might be thinking, well, isn't that too many? Well, it may be, but as long as you are able to articulate a larger conceptual framework that draws from these various constructs and theories, then it can make sense. And I'll show you an example of that. What about if I need to develop an implementation strategy? So going back to what I was talking about, strategies, but now with the knowledge of some of the theories and stuff, how do I do that? How do I use these theories? And what if I need to develop implementation strategies? So most people can intuitively think that, well, it's kind of like how we do other things. We conduct an assessment of factors to influence implementation. And then we develop or select or tailor strategies to address it. Well, it's true, but the bad news is it's not quite that easy. And I like this quote from Albert Einstein: everything should be made as simple as possible, but not simpler. And this goes back to sort of our tendency to want to just choose from a list of implementation strategies, right? And so work that is, I think, really important now is trying to develop methods to improve the selection and tailoring of implementation strategies. And there are a number of them, but I'm going to briefly mention intervention mapping here. So intervention mapping is a systematic approach for intervention development, implementation, and adaptation. And there's basically 3 ways that intervention mapping can be used to advance dissemination, implementation, science, and practice. The first is in what we call designing for dissemination. And it's designing interventions in ways that enhance its potential that it will be used. And so a lot of concepts that people are talking about in this area of designing for dissemination, that includes things like engaging stakeholders and implementers from the beginning, understanding their context, understanding their motivations, et cetera. As you're developing the intervention, as you're developing the innovation, that's one way that intervention mapping can help. Another one, and probably the one that's most relevant for what we've been talking about, is designing implementation strategies to influence adoption, implementation, and continuation. And this is what we call implementation mapping. And then finally, it also can be used to adapt existing interventions. So what is implementation mapping? So implementation mapping simply is the use of the intervention mapping protocol for planning implementation strategies. And even though this step was always in intervention mapping, as part of good planning of interventions, you think about planning for its use. I realized several years ago that even though it exists, it wasn't well known. People were not necessarily using it to plan implementation interventions. And we published this article last year, and it received a lot of attention and continues to do so. And I think that represents that there's a real gap in sort of making this connection about how do you go from understanding what the problems in implementation are to developing or choosing the strategies to help address those problems. So I don't have time to go through the various steps, but just to say that the implementation mapping protocol helps you answer questions about who has to do what for adoption, implementation, and maintenance. Why would they do it, and how? This is important. The mechanisms. How do we change those determinants? This is a model that's included in that article, and it demonstrates how we use logic models to develop implementation strategies. And when the planning process, as you can see, goes from thinking about those outcomes that you want, and you might not need all 3, you might be specifically focusing on implementation, and then how you have to think through who has to do what for this to happen, what are the factors that influence it and the contextual factors, and then what are the specific mechanisms and strategies that are going to be needed to actually implement this innovation. This is a real life example that was just really recently published from a study that led by David Wetter in Utah, Quit Smart Utah, on increasing quitting of smoking cessation in primary health care. And I just wanted to show this model because it's an example of how we used theories, both framework and implementation science and behavioral science theory, to inform the intervention mapping process, the implementation mapping process, to develop the implementation strategies to reach the outcomes that we were trying to reach. So I'm going to wrap up with just saying a little bit about some research, D&I research needs and opportunities. There's a lot of work that still needs to be done in adaptation of evidence-based interventions, designing for dissemination, sustainability, dissemination and scale-up, de-implementation, which is defined as the stopping practices where there's no evidence of patient benefit or where there's evidence of more harm than benefit. There's a lot of work that needs to be done in that area. And in fact, there is a notice of special interest right now, specifically related to de-implementation, implementation of precision medicine approaches and genomic medicine, And then methodological advances such as use of big data and adaptive designs, implementation of multi-level and complex interventions, and one that I'm very interested in and I think also needs a lot of work is implementation to increase health equity. So Bijal already mentioned several of these resources. I will just leave them up here for a minute. I will point out that next week there is a 2-day conference. It's Implementation Science for Cancer Control. And it's going to highlight some of the excellent work that some of the newly funded ISC3 sites have done in implementation science. And then also, I was going to list in a slide a lot of funding opportunities, but realized that this page from University of Washington's Implementation Science Research Hub, and the URL is down here, has a really excellent compilation of various funding announcements for implementation science. So I encourage you to look at that. So in summary, implementation science can help bridge this research to practice gap by building this actionable, pragmatic knowledge base that can help us not only understand what influences implementation and dissemination, but also to develop strategies that can help accelerate this process. So there's a lot to learn. And in the next 3 seminars, the speakers will cover important topics that we've talked about. And we hope that you'll join us for that. So we're going to take the last 10 minutes or so to entertain some questions. I'm going to end this slideshow and stop sharing.
So thank you, Dr. Balasubramanian. Thank you, Dr. Fernandez, for the great information. I know I took lots of screenshots and found a lot of great resources. We do have a few questions that I'm going to read out, and I want to encourage everybody to enter other questions if you have them. The first question is, do you have any resources or examples of implementation strategies that are connected to strategies around cultural relevance? It would just be interesting to see how these strategies have been adjusted in different settings and for different populations.
Bijal, do you want me to take that one? So I think, I think I understand that your question, and you're talking about specific strategies that may have been used in one setting, but that setting is not necessarily one that is serving a particular population, and then when you're adapting it. The whole area of adaptation is, I think, a really critical one. And when I talked about it here, I talked about adaptation of the evidence-based intervention. But adaptation of strategies for implementation is just as critical, and sometimes even more critical than adaptation of the intervention itself or the innovation itself. Maybe the innovation doesn't really need to change that much, but the way that it's delivered does. And so, yes, I can think of a number of different examples where we've done that. And I would say that if you look at the adaptation literature, there are some frameworks for guiding adaptation. I mentioned intervention mapping as one of the frameworks. IAM-ADAPT is what we call it. But there are other frameworks that explicitly ask questions about population and setting in terms of implementation. But I would be happy to talk more about it with you if I could. Feel free to contact me.
Wonderful. We've got another question from a clinician who is asking, what preliminary work is typically done to inform a comprehensive implementation strategy prior to a pragmatic trial for a clinical intervention?
Bijal, you want to take that one?
Yeah, I can attend that. So in fact, I would encourage you to take a look at that detailed logic model that Dr. Fernandez had presented, and you'll see it in the slides and the recording. But one of the things, and I do some work in developing implementation strategies for adopting clinical interventions, and really one of the critical pieces of things we do is develop this logic model and conceptual framework of how I'm hypothesizing, how we're hypothesizing that the actual adoption of the actual clinical intervention will then be implemented. And I think that often we don't spend enough time thinking through the logic of taking this intervention and who is going to implement it. What is the practice change effort that's needed to implement it, and draw out that logic of it? What specific preliminary or process outcomes it's going to impact before we go on to the downstream outcomes. And often in clinical studies, the implementation pathway that I showed, where it's in the middle, what are the strategies and what are the implementation outcomes, don't get enough attention and thought in designing that intervention. So I think that the middle of that implementation pathway, through conversations and discussions with your multidisciplinary team, and in particular with your clinical stakeholders and patient stakeholders, can help get more clarity in not only thinking through all of the different components of it, but then also when it comes down to implementing it, will provide a little more clarity in implementation.
Thank you. Let's have one more question. And this one is really just talking about some challenges. And the challenge in particular is the link between the research question and the implementation research framework. And what are some of the challenges with getting that correct and making it as useful as possible?
Yeah, so I think that I'd like to think about implementation research in a similar way that we think about intervention research in general, right? Like you want to understand the why, what are the factors influencing implementation? And so there are particular frameworks and those determinants frameworks, like CFR, but there are others that can help guide you in asking the right questions about the why, right? Because they have these constructs, what's happening in the inner setting, what's happening in the outer setting. And so research questions that are trying to understand the why, often I would go to determinants questions, determinants frameworks. If you're trying to develop an intervention and you really need a process or a protocol on how to do it, then I think something like intervention mapping is really helpful, because it's really a step-by-step approach and tells you, how do I incorporate this, what I'm learning, what I understand from other frameworks into the planning process. And then outcomes, I find the REAIN framework or these other evaluation frameworks in implementation science really helpful for trying to answer questions about, did it work? What was the reach? What was the overall impact? What was the penetration? What were those outcomes? And how can we characterize those outcomes in our studies?
Thank you so much. So for the sake of time, I'm going to thank everyone for attending today. As our speakers have done, they've encouraged all of us to continue to explore this area. Our next webinar is on September 29th at 2 p.m. Central Time. Dr. Abe Wandersman is sure to be a fantastic speaker. And again, thank you to Dr. Balasubramanian and Dr. Fernandez for really just kicking off this series in a dynamic way and getting us all engaged and ready for the next steps. We hope everybody has a terrific day. Know that this has been recorded and you'll be able to access that in the future, and we hope you do. Thanks so much.
Thank you.
Thank you.